So apologies, everyone. I think the reconnection was not letting us share the screen. So now it's happening. So just let me remind you that you have the option to raise your hand to ask any, to make any comment, and you have the option of asking a question by typing it in if you don't want to forget it, or you can keep it for later. When you raise your hand, we can unmute you. We will be allocating a specific time after a new session for questions and comments. So the Global Evidence Synthesis Initiative is founded by Cochrane, the Alliance for Health Policy Systems Research, the Campbell Collaboration, the International Initiative for Impact Evaluation, the Epicenter, the American Institutes for Research, the Collaboration for Environmental Evidence, and the Joanna Briggs Institute. And GESI is an initiative to build and strengthen capacity in evidence synthesis in low and middle income countries. It supports the production and use of evidence synthesis across all sectors, including but not limited to health, education, law, crime and justice, and others. The GESI Secretariat is hosted by the Center for Health Policy and Systems Research for Health Policy and for Systematic Reviews on Health Policy and Systems Research, SPARC, at the American University of Beirut. And the Secretariat team includes myself, the Secretariat Coordinator, Hassan Ribmani, the Administrative Assistant, Eli Ael and Fadi Al-Jardari as the co-directors. The GESI network is a network of centers for evidence synthesis that have already been established in low middle income countries and aims to build partnerships and collaborations and to strengthen capacity in multidisciplinary evidence synthesis production and use in low and middle income countries. The eligibility criteria to be part of the GESI network is 1, to be part of an institution, to be based in the low middle income countries, and 3, to have published at least 2 systematic reviews. So at this, right now we have 38 centers from 24 countries, and we have a link where you can see the list of the centers that are part of the GESI network. We can share these slides later, and please make sure to go to our website to find out about these centers. If you are attending the Global Evidence Summit in Cape Town next month, we will be hosting 2 workshops and a couple presentations. So for the workshops, we have the Capacity Building and Conducting Systematic Reviews workshop, and then Making Systematic Reviews Impactful Through Knowledge Translation Strategy Tools. And we will be having a poster session to introduce GESI. If you are not attending, we will be live streaming all our events. Make sure to subscribe to our YouTube channel. So for now, today's session is about the healthcare information for all HIFA that will be delivered by Neil Pakenham-Walsh. So let me start by introducing Neil and thanking him for being with us today. So Neil is the coordinator of the HIFA campaign, Healthcare Information for All, and co-director of the Global Healthcare Information Network. He is also currently chair of the D Groups Foundation, a partnership of 23 international development organizations promoting dialogue for international health and development. He started his career as a hospital doctor in the UK and has clinical experience as an isolated health worker in rural Ecuador and Peru. For the last 20 years, he has been committed to the global challenge of improving the availability and use of relevant, reliable healthcare information for health workers and citizens in low and middle income countries. He is also interested in the wider potential of inclusive, interdisciplinary communication platforms to help address global health and international development challenges. He has worked with the World Health Organization, the Wellcome Trust, Medicine Digest, and INASP, the International Network for the Availability of Scientific Publications. He is based near Oxford, UK, and we are very happy to have Neil with us today. Hello, Neil.
Hello, thank you very much, Tamara. So I will now try to share my screen. Thank you very much, Tamara, and welcome everyone and thank you for joining us today. I'm going to be speaking for about 20 minutes about HIFA, Healthcare Information for All. And we're a global community of 17,000 members in 177 countries. There is our website, hifa.org, and at the bottom, my name and email address. We're going to start with a poll to see where everyone is coming from today among the attendees. So I'm going to pass this straight back to Tamara to do this, but here is just what we're going to do is going to ask you to indicate which of the WHO regions you are in, and these regions are the Africa region, the region of the Americas, Southeast Asia region, European region, Eastern Mediterranean, and Western Pacific. And I understand that we have combined the Southeast Asia and Western Pacific because there was only room for 5 options. I'll pass over to you, Tamara. Thanks.
Great. So you should have a pop-up screen right now that gives you the options. And please go ahead and click on the option of where you are from. And I think the poll has been completed.
Excellent.
And here are the results.
Great. So we've
Can
got...
you see the results?
Yes.
Great.
Would you like to read them tomorrow, or shall I?
Yes, definitely. So we have the majority from the Eastern Mediterranean region with 44%. We have 33% from the European region and 22% from the region of the Americas.
Great. Wonderful. Thank you. So moving on. Oops. I've already been introduced, but basically just to say that I'm based here near Oxford in the UK, and I don't need to go over my bio again, but I'm particularly interested in meeting information needs. And some people have said you could have saved a lot of time not qualifying as a doctor and doing all those other things. You could have started off simply qualifying as a librarian and getting on with it. And in many ways, my mindset, I think, is similar to that of many librarians. So the outline for this talk is I'm going to say why is needed, what are we trying to achieve, how are we achieving it, how you can join, and then a few thoughts on how HIFA and GESI might collaborate, and then we'll open up for discussion. So the basic reason that HIFA is needed is because people are dying for lack of knowledge. Every day, thousands of children and adults are dying needlessly because they don't receive basic life-saving interventions. Now, the important point here is that these interventions are actually often locally available, but are simply not provided due to indecision and delays, often among families and caregivers, but also having arrived at a health worker, there are problems of misdiagnosis and incorrect treatments. And if we can look at ways, causes of death in many different ways. We can look at causes of death in terms of medical causes of death, such as pneumonia, malaria, etc. Or we can look at causes of death in terms of the more fundamental reasons, as in social determinants of health, such as poverty and so on. But the area that HIFA is particularly interested in is the causes of death or avoidable suffering that result from poor quality of care. So, for example, with child diarrhea. Now, child diarrhea kills 1,000 children a day just in India alone. And the main reason is basic errors in care from parents and or from health workers. So research has shown that only 1 in 10 children with diarrhea in India receive increased fluids to prevent death from dehydration. So we're talking about very, very basic treatment. And 4 in 10 children are said to receive less to drink than normal, thereby tragically increasing their risk of death. There is still quite a prevalent belief in India, and I understand in some countries in sub-Saharan Africa as well, that if a child develops diarrhea, then the right treatment to do from the point of view of the parent is to withhold fluids, which of course tragically increases the risk of death. In 2009, I did a literature review with my colleague, Dr. Frederick Bukacci, on the information needs of health workers in developing countries. And our conclusion was that there is a gross lack of knowledge about the basics of how to diagnose and manage common diseases, going right across the health workforce and often associated with suboptimal, ineffective and dangerous healthcare practices. In effect, many people, a large majority of people around the world, are not receiving the benefits of modern medical care. So what is HIFA trying to achieve? Well, we're looking to create a world where every person has access to the information they need to protect their own health and the health of those for whom they are responsible. So we look at the information needs of the general public, of parents, families, children. We look at the information needs of health workers at all different levels, and we also look at the information needs of policymakers. And our focus is on low and middle income countries because this is where the biggest gaps are. Now, when we launched in 2006 in Mombasa in Kenya at the Association for Health Information and Libraries in Africa, we had a letter of support from the World Health Organization, which included the words, HIFA is an ambitious goal, but it can be achieved if all stakeholders work together. And I'll try to explain what I mean by that in forthcoming slides. How are we achieving our goal? Back in 2004, I was the co-author with Fiona Godley, who is now the editor-in-chief of the British Medical Journal, and colleagues, on a paper that we titled, Can We Achieve Health Information for All by 2015? And this was published in The Lancet. And in the paper, we described what we called a failure of the global healthcare information system. So this is the whole system of what needs to be functioning in order to make information available in the right format, in the right language, at the right time for people. So here you have the whole gamut of understanding information needs, undertaking and publishing health research, producing systematic reviews and guidelines, producing reference and learning materials, and then the whole business of making information available in the right formats to different audiences. And essentially this system, we argued, is not working. It's evident that it's not working because people, particularly in low and middle income countries, simply do not have access to information that is understandable, relevant and reliable to help them guide decisions. Our strategy then is to try to actually enhance or increase the functionality of this global health information system. So the global health information system is represented here in the action area. You'll see that that's a smaller version of the slide that I've just shown you. And on the left, you'll see what is the Haifa strategy to strengthen the system, to try to push the drivers and address the barriers. And our strategy runs from the bottom up. So it's first of all about better communication among all the different stakeholders within the system, which is represented by the HIFA forums. The HIFA forums generate better understanding, which is captured in the HIFA Voices database. And then we use that better understanding for advocacy to persuade governments and funding agencies to invest in effective ways of improving the availability and use of health information. And our intention is that all of this will, through strengthening the system as a whole, will make a contribution to reaching the HIFA vision. We have now brought together more than 17,000 members on 5 forums in 3 different languages. You'll see here that we have our main forum is HIFA, and along the bottom we have CHIFA, which is Child Health Forum, HIFA Portuguese, HIFA French, and HIFA Zambia. Bottom you'll see on the left the BMA logo, the British Medical Association, which has been our lead funder for the last 9 years, and the World Health Organization, which has been our lead strategic partner. And I would add that in terms of the members, the membership is distributed worldwide according to how you might imagine for language. So for example, for our English language forums, we have around 5,000 members in sub-Saharan Africa, 5,000 members in Europe, and 7,000 members in the rest of the world. Actually, that's the pattern for the whole of the 5 forums. Clearly, for the Portuguese forum, we have large numbers in Brazil, Angola, Mozambique, and so on. This is a chart of our growth, so you can see that we are still growing quite linearly and continuing to grow year by year. And we welcome new members all the time. This is a screenshot of our HIFA Voices database, and here you can do searches on what we call HIFA quotations, which are verbatim extracts from HIFA messages that illustrate points around information needs and how to meet them. And we also have on this database HIFA citations, which are citations to library and information services literature. The intention is to use our forums and database to generate or to support evidence-informed advocacy, and I think one example of this was back in 2012. We collaborated with the New York Law School on a white paper which concluded that governments have a legal obligation under international human rights law to ensure that citizens and health workers have access to the information they need to protect their own health and the health of others. And we, of course, use this to underpin our advocacy. We're now ready for the second poll, which is to introduce how you can join HIFA. But before we do this, we'd like to know, please, if you're already a HIFA member. And so I'll pass you again back to Tamara to do the poll. Thanks.
Thank you, Neil. So here is your next question. Are you a HIFA member? Thank you. So we have the majority.
Thank you.
Apologies,
yes, we have the results.
So we have the majority who has answered, and most of the attendees today are not HIFA members, but we do have 30% who are HIFA members. I think this is a great combination.
Excellent.
Back to you, Neil.
Thank you. And I noticed a few colleagues among the names. Hello, Malcolm Brewster and Claire Allen. Yes, the next slide is for those who are not yet HIFA members. And I'd really love to encourage you to join us. And you can do so by going to our website, hifa.org, and click on join, or you can go direct to the join page, hifa.org/join HIFA. And of course, it's free of charge. You will be part of an email discussion forum, and you'll receive 1 message per day with a compilation of the messages sent during that day. The forums are moderated, so essentially all of the content that is coming to you will be relevant and will hopefully be useful to you. For those who are already HIFA members, there are lots of ways you can engage even more than just being a member and receiving and perhaps contributing to the discussions. So we have an increasing number of country representatives all around the world who are volunteers who promote HIFA in their country and help us our membership in those countries. So they do a fantastic job, and it's a good way of raising your professional visibility because you get a profile on our website and so on. You might also like to consider your organization becoming a supporting organization. Now we have 299, so perhaps your organization could be number 300. Again, all around the world. Most of these organizations do not provide financial support, that there's no obligation to do so. Many of them do provide in-kind support or involvement with the different HIFA projects. And here I'm coming on now to the 12 HIFA projects that we have running at the moment. This is actually expanded from just 7 projects last year, so this is a big growth area, if you like, in the HIFA program. Here are some examples of HIFA projects, and the ways that these work. Well, the way that these work is that HIFA members come together in special interest groups, which are generally between about 6 and maybe 20 people, 20 HIFA members, to address particular issues. And the first function that HIFA projects have is to stimulate discussion on the HIFA forums themselves. In other words, we aim to leverage the main strength of the HIFA initiative, which is its large membership. And I've put evidence-informed practice in bold because it's particularly of relevance to how HIFA and GESI might collaborate in the future. Indeed, in a sense, we already are informally, in that Tamara has recently joined, back in April, has joined our HIFA project on evidence-informed policy and practice. So this project is sponsored by TDR, the Special Program on Research in Tropical Diseases, the World Health Organization, and the Lancet. And we also have members representing the Cochrane Collaboration, which is another HIFA supporting organization, JBI, the Joanna Briggs Institute, another supporting organization, the Campbell Collaboration, and GESI. So our work during 2016 and 2017 has been to run in-depth thematic discussions on issues relating to evidence-informed policy and practice on the HIFA forums. So we've run 3 of these discussions so far. The first was on country-level policy making, and this was presented at the Cochrane Colloquium in Seoul in South Korea in 2016. The second discussion earlier this year was on implementation research and will be presented as a poster by one of our group, Samyudeep Baumik, at the Global Evidence Summit in Cape Town shortly. And the third discussion, which recently concluded, is on systematic reviews, and that also will be distributed at the Global Evidence Summit. And the 3 points perhaps coming out of the systematic review discussion where HIFA and GESI and others could go into more depth. And those are to do with the questions of how to strengthen the production of systematic reviews, particularly in low and middle income countries. How to improve the general understanding and use of systematic reviews. There is apparently some ideological resistance still to systematic reviews, which we are looking into. Perhaps the most interesting is the potential, or the challenge, if you like, to synthesize systematic reviews with local research. We've learned in our systematic review discussion that local policymakers, national policymakers, tend to prefer research that has been conducted in their country, but in some ways this could be seen as a prejudice, and what is unclear and what we perhaps could work on more is how better to synthesize systematic reviews and local research evidence in the form of policy briefs and so on. I conclude with just giving some acknowledgements, first of all, to our financial supporters in 2017, whose logos you can see here, 40 of them. But altogether, the financial support is in the region of 45,000 US dollars per year. So we are not a large organization. In fact, we've got 1.5 members of staff, and we are very keen to double our income and double our staff capacity so that we can do more. One of the reasons we are able to achieve a lot is because we have a large volunteer base. We have more than 250 volunteers around the world. The HIFA steering group, the different steering groups for the other HIFA forums. We have a social media working group. We have a Twitter account and also a Facebook account. We have a volunteer HIFA webmaster. As I mentioned, we have many HIFA country representatives, and we recently started a CHIFA country representatives program. And we have all of the various HIFA volunteers who are working on our 12 different projects, in addition to local volunteers here in Charlbury near Oxford who help out with various bits of administration. So there I come to the end of my presentation, and I look forward to discuss with you and to answer any questions. Thanks.
I'm sure everyone is very excited to join HIFA. We are opening now the floor for discussion if anyone would like to ask anything or make a comment or talk about their experience. So we're starting with Sunanda Kohli. Okay, Sunanda.
Let you know that while my presence has not been documented, it's possible that in India there are several others who have joined, but the submission was not documented. I just wanted to bring that to your notice. Thank you.
Thank you. Any questions from, would perhaps, if Malcolm and Claire are still on the line, would they perhaps like to say a few words about their work on the project working groups or their experience of using HIFA?
So Claire?
Yeah, just to say that I've been on the project working group. The most recent one, sorry, the reason I'm muted is my house is quite noisy at the moment. The most recent one that I'm on is about library information services and how that can help in global health. I'm struggling to say something that won't feel very out of context, but just to say that Evidence Aid and HIFA are going to be working together in advance of Humanitarian Evidence Week between the 6th and 12th of November to start a whole new discussion on how librarians and information services can help provide evidence after humanitarian crises and disasters, kind of global health epidemics, those kinds of things. So yeah, I would really encourage people to get involved if they can. And by the way, tomorrow, if you want me to do an Evidence Aid presentation like Neil's just done, then I'd be happy to do that, and it might provide a little bit of context to what I've just said.
Yeah, that would be great. Thank you, Claire. We can do a very brief one here, and we can set another one for another day.
So very quickly, Evidence Aid is a charity. It's very small. It's much like HIFA in terms of its staffing, and we look at advocating for evidence-based decision-making after disasters and humanitarian crises. That's probably it in a nutshell. Like HIFA, we also rely hugely on volunteers, so if that kind of floats anybody's boat or anybody is particularly interested in the humanitarian sector, then I'd be really happy to hear from them.
Thank you, Claire. Thank you very much. So Neil, we have a question from Derek Brown. Derek? Okay, so Derek sent a question saying it would be great to receive one summarized or truncated email per day, as you mentioned, Neil. At the moment, I'm receiving up to 10 HIFA mails per day, which, while interesting, is too many.
Yes, thanks, Derek. I can help you with that. The default position for new members up until fairly recently was to go on to what we call an immediate setting, which is where you get each message as soon as it's approved by the moderator. But we've learned through the increase in numbers of messages that are distributed on HIFA, which is probably on average about 7 to 8 per day now, that many members do prefer to have the messages delivered on a daily basis as a compilation. So I will look you up, Derek, and make sure that you have a daily compilation from now on.
Great. Thank you, Neil. So the next question is by John. And John's saying that is HIFA working with students in information sciences study programs to become low-cost members of a variety of regional partners, of regional or national professional associations. I'm thinking of our Association of Population Libraries and Information Centers, APLICI, which is offering free international memberships during our 50th anniversary, 2017-18.
Sorry, I didn't catch that all. Could you please repeat it, Tamara?
Yes, definitely. So the question is HIFA working with students in information sciences study programs to become low-cost members of a variety of regional or national professional associations?
Fine. If I understand that correctly, does the question mean that if somebody becomes a HIFA member, then they automatically qualify for some kind of reduction in the cost of membership of another association?
I think so, but maybe we can try to unmute John. And John, would you like to explain a bit?
What I'm thinking is that professionalization of library science starts when the students are in their graduate studies. And there are not very many library school training in Africa, for example. I'm wondering if we could encourage some of those students to join as low-cost student members to organizations like APLIC or AHILA or some of the other regional library associations. I had just learned that Moi University in Nairobi offers 4 different graduate study programs in information sciences, but I have not heard of a Kenyan library association that should embrace those students and help them in their career paths.
Okay, I'm still not completely sure, but the AHILA is one of the organizations that is a HIFA supporting organization, and AHILA stands for the Association for Health Information and Libraries in Africa.
Yes.
There are other. That is, I think, the main regional association for health information and libraries. AHILA has members who are members of HIFA working groups, and we are in regular contact with one another. And also, AHILA, of course, has links with particularly the National Library of Medicine in the States, and IFLA and other organizations. IFLA, for example, the International Federation of Library Associations, very recently took on Dr. Maria Musoki, who is a professor of library and information sciences in Makerere University, Uganda. And she is now the head of the Health Libraries and Bioscience Group at IFLA. And she's also a member, along with Claire, of the HIFA Library and Information Services project. I think that where HIFA can help in terms of awareness of is often to do with awareness of different associations and different opportunities that can be made available. So if AHILA wanted to put out a a notice about some opportunity that has come up, or if indeed another library association wants to do likewise, HIFA would be an excellent way to publicize what they do and publicize what the opportunities are to different people. I'd also add that when HIFA first started, given that we started at the AHILA Congress in Mombasa, HIFA originally started with mostly librarians, and although the proportion of librarians compared with other professional groups has changed over the years, library and information professionals are still a major group among us.
Good. I'm glad to hear that, Neil. You know that I'm a real proponent of use of Hinari and have worked with Lenny and the WHO librarians to train as many people as I can in developing countries. But I was also aware with working with librarians in Bujumbura, of which there are very few librarians in Burundi, that there are very few library training schools in Africa. And yes, I would think it should be a wonderful thing for HIFA to endorse students for low cost or free membership in the existing information sciences associations like AHILA. And yes, IFLA, if Maria can get that information through your
yes.
HIFA blog, I would really strongly encourage us to do that. Our association is only 50 members from major universities, with only 10 of them being international. And we want to build or double our membership this year by inviting free memberships for international practitioners and students.
Great. Well, the way forward for this, Jean, I would suggest is either you could send a message with this idea and proposal to the HIFA members as a whole, yes, and see where it goes, or you can send it to me if you prefer, and I can share with the Library and Information Services Project Working Group, and we'll try and work something from there. It's whichever you feel comfortable with.
Good. I'll probably do both this weekend. Thank you.
Great. Wonderful. Thank you, Jean.
Okay, this is great. So do we have any other question? Neil, did you want to ask Malcolm about his experience?
If you're willing, Malcolm. Malcolm's a member of our working group on information for prescribers and users of medicines, which is one of our most active groups. And Malcolm has been very generous with his time in helping us with a review of this area. I'm not sure whether he's still with us. Yes, Malcolm?
No, I don't think so. Maybe Malcolm's having some difficulties, but if anyone else would like to ask anything for Neil, please go ahead. We still have a couple minutes before we close up for today.
I'd be happy to make a few other comments while people are thinking about questions. One comment to make is that increasing access to information is much more than simply increasing connectivity. The increased availability of information through the internet and through mobile phones and so on is wonderful, but it also creates problems of finding the right information from among what is becoming increasingly too much information. And a good example of this was what happened in the Ebola crisis, where myths and rumors about how to treat yourself for Ebola or how to protect yourself from Ebola were going around the mobile phone networks, and may well have contributed to fear and indeed possibly infections. That's one point I wanted to make. Can I make another point?
Yes, sure, go ahead.
Oh,
yeah.
Thanks.
We're listening, Nick.
Okay, great. Now, another point I wanted to make is that the kind of information that is leading to deaths in low and middle income countries. The kind of information that we're talking about is not, by and large, highly technical information. It is very often gross errors in care. One of my favorite books, and a book that I used a lot whilst I was a doctor in Peru, is the book Where There Is No Doctor. And it's amazing to think that just within the pages, those 200 pages or whatever of diagrams and text, is much of what is needed in terms of dealing with common life-threatening illnesses. So, but having said that, systematic reviews are, and I believe have to be, at the center of the information system. It has been a revolution in the last 20 or 30 years to move towards evidence-informed medicine, evidence-based medicine, and systematic reviews I consider are incredibly important in that. But they are important not because they themselves necessarily have to be disseminated and used, but because they need to be used to underpin the kind of basic evidence that one sees in such as primary healthcare manuals.
I would definitely agree with that, Neil. So Claire has a comment to add. Claire?
Yeah, I just wanted to say that that's exactly why Evidence Aid provides freely available systematic reviews in reference to the humanitarian sector, because the humanitarian sector generally hasn't traditionally used systematic reviews, but I think that systematic reviews are more aimed at the people that are setting the standards or the policies than they are to your kind of everyday healthcare provider. That's not to say that I think they shouldn't be accessible to the everyday healthcare provider, which is why we write a very simple summary to enable people to decide whether they want to read further for each systematic review we upload. But I'm completely in agreement with Neil that it's kind of, I think, understanding why a systematic review is important and how you actually get the information into a systematic review is actually enough for a lot of people to then understand why a systematic review would underpin an evidence-based decision.
Yes, indeed. I'd add that in the global healthcare information system that we described in the Lancet, the natural customer, that's a funny word, but the natural sort of reader or target audience of systematic reviews within the global healthcare information system is arguably the developer of guidelines, such as the guidelines that are produced by the World Health Organization. So we have systematic reviews which are generally global geographically in scope that are then taken into consideration and form the basis for international guidelines. Then we have the more sort of, I think, possibly more messy process, and possibly needs more attention, is the process of national policymakers interpreting international policy guidelines and or the systematic reviews on which they're based alongside local research. And I think that that is an area where there is a lot of progress is yet to be made.
Yeah, I completely agree, Neil. And it's one of our biggest challenges is thinking about the contextual information that's needed in order to make those systematic reviews useful.
Great, and I would only agree with both of you. Claire, we had an experience ourselves with Spark when we published our systematic review about providing coordination services in humanitarian crises, and we were very happy with the summaries because they definitely informed all those who were not familiar with the concept of systematic reviews, but were interested in the topic, so it was a good guidance for them to go through the paper.
And you might want to know, Tamara, that those summaries all have been translated into Spanish, and we're working our way through French. So right. From your review that we have on our website, the summary is translated to Spanish and French now.
Very nice. Thank you very much. Neil, back to you. We have a comment from John, who is saying, good to point out that Hesperian society, where there is no doctor, is free to practitioners and libraries in low middle income country areas. Many healthcare providers do not read systematic reviews, but we can utilize them to coach those who are training medical workers. So, John, if you'd like to elaborate on that, please go ahead. No, go ahead, please.
I work for a Johns Hopkins affiliate called GEPIGO, which trains particularly nurses and midwives in low income or low resource settings. And we're really very conscious that many of the faculty members are training their students, particularly medical schools, on 30-year-old curriculum where there are no books, for instance. And so they just have canned lectures. And I think that we as librarians can kind of guide some of those faculty members into some newer concepts, perhaps systematic reviews on leading causes of death in Africa, which I shared on a Yammer with our colleagues, is a good sort of review to point out that although malaria and diarrheal deaths are dropping with some of the vaccines and prevention, they should be teaching towards some of the non-communicable diseases and recognition of their impact on African communities, heart disease, cervical cancer, other preventable diseases should be more taught, I think, in some of the medical training institutions. And GEPIGO is certainly working on lessening maternal deaths and newborn deaths with our training programs, which we hope to integrate into the major training institutions in the 40 countries where we work. But librarians can be very key in channeling information. Claire, I am looking forward to those French translations particularly of your summaries of systematic reviews, which may make a difference in the teaching capacity of our colleagues in those training institutions.
Yeah, there are quite a lot up there already, and as I said, we are working our way through getting to the end of them.
Great. If you could post another link to the repository on the next HIFA posting, Neil, that would be great. It's almost time. I'm going to mute.
Okay, great. So thank you, Claire, and thank you, John. I think we are going to close here. So Sunanda, did you have any other comment? I see your hand raised.
I just have one comment, because when we're talking about evidence informed policy and practice, for all low middle income countries, I think local research has to be synthesized with the systematic reviews, and finding how to do it would be very important, as also implementation research, where I think policymakers would be very interested.
Definitely. So this is actually in alignment with what HIFA is doing, and definitely what GESI was made for. So as Neil mentioned, HIFA has had thematic discussions on evidence-informed policy, a working group, about evidence-informed policy and about implementation research. And so just to remind everyone that GESI, the Global Evidence Synthesis Initiative, was built to strengthen and build capacity in producing and using systematic reviews in low-middle income countries to impact practice and policy. And so in our capacity sharing and building activities, we will be focusing on starting with how to produce evidence synthesis. And that's why we have the other webinar series, the Cochrane Learning Live and GESI webinar series. That specifies in discussing different types of evidence syntheses. And then we have this webinar series that gives chance to the GESI network members who are from low middle income countries to talk about their own experience and their challenges that they're facing when using evidence syntheses to inform practice and policy, so that we can actually work on that and hopefully achieve a better evidence-based policy making and practice making in low middle income countries.
Thank you.
So, sure. So, Neil, if you'd like to add anything else before we close. Neil, are you with us?
Sorry, sorry, I was on mute. Just to say thank you to everyone for joining us, and thank you to you, Tamara, and to GESI for hosting this webinar, and looking forward to further collaboration.
Great. Same here, Neil. Thank you very much for this presentation. And we will also be running activities together at the Global Evidence Summit. Don't forget to subscribe to our YouTube channel and follow us on social media to follow up with the activities at Cape Town in September. Thank you, everyone.